Good afternoon, everyone, and welcome to this edition of Macro Pro and Friends. I'm Diane Cohen, Vice President of Client Services and Education. It's been my pleasure to put together this summer school series for all of you. You guys have been fantastic. I noticed there have been names where people have attended more than one, so we're delighted. We always would love to get your feedback on our speakers, our topics, and what you would like. So be sure to send those emails to me or put it in the chat box. I'm joined today by Jenni. How are you, Jenni?
I'm doing great. How are you, Diane?
I'm good. And I want to apologize to everybody that we had the last time had to cancel because of this little guy here, Mr. Gizmo. He is still very, very sick, but he decided he was going to make a cameo today. And so we're glad to have him join us. So Jenni, can you tell us about you and the company that you're representing?
Absolutely. My name is Jenni McDowell. I am the Chief Marketing Officer for 2 hospitals in California, acute rehab facilities. Vibra Hospital, or Vibra Healthcare, is our parent company. And we have a location in Fresno, which is San Joaquin Valley Rehab Hospital, and also Ballard Rehab Hospital down in San Bernardino in Southern California.
Oh, very nice. So Jenni, when we get started with our webinar series, we always ask a question about the summertime since it's a summer school. Do you have a question that you can ask our audience?
Sure. So being a vegetarian, I'm always curious what vegetables they like to grill. Always curious about
that. Okay, so please put that in the question box. Tell us which vegetables you like to grill. And then tell us, Jenni, what do you like to grill?
Corn on the cob is one of my favorites. Whether you can put a little bit of tahini in the aluminum foil and put that on the grill, it's excellent.
Oh, wow. Right away, we're seeing corn on the cob, corn and onion, squash, mushrooms, and these are all people I could see their names. They've attended other webinars. So thank you guys for hanging out with us today. Corn, squash, and onions. That would be a really good combination as well. I love grilled zucchini. That is so good. Oh, look at that. Jennifer agrees with me. She put that down just as I said that. So, all right. Love that. All right. Well, I'm going to turn this over to you. Oh, no, I'm going to do a little housekeeping. I get so excited when I see these answers from everybody. It's lovely to see people participate. All right. So today's webinar is worth 1 CEU. You have to be logged on to go to webinar. You need your own link that you registered for if you're using somebody else's. The certificate will be in their name. So let's make sure we just register and you'll get it in your name. The certificate should come to you within 1 hour. Sometimes it takes a little longer because of firewalls companies have. If you have any questions at all, please put it in the question box, just like you put all your favorite vegetables to grill. You use that same box and we'll have questions for our experts. And then lastly, there are handouts of this presentation, so please be sure to download them so that you have that. All of our webinars from the summer series are up on the Macro Pro YouTube channel. So please take a look at those. We do not provide credits when it's on there because we can't record time and attendance, but they are still excellent to learn about your craft. All right, Jenni, I'm going to turn this over to you now.
And I tried to open because I wasn't seeing all the vegetable answers, so I closed that. So I want to make sure we have our chat area open. All right, thanks, Dan. Thank you, Mr. Gizmo. So I'm Jenni McDowell, Chief Marketing Officer for several acute rehabs in California. We are going to provide an overall view of what inpatient acute rehab looks like and how you can get an injured worker into that setting if a different setting isn't working for them, whether it be their outpatient therapy that they're doing, or they may be in a skilled nursing facility or home being taken care of by home health. I have a few folks that are going to help me with that today. Thank goodness. I have my CEO, Chase Taylor, who is also an RN. I have Meegan Kliewer here. She is also one of our lead therapists. She is a physical therapist as well. So I'm going to kick it over to Chase and he will start.
Hey there. So in making an informed decision about where you're going to send an injured worker, I think first you need to know what exactly is what exactly is a acute inpatient rehabilitation hospital? So an acute rehab hospital, or we call them IRFs. We use the term IRF, that's IRF, inpatient rehab facility, is licensed as a general acute care hospital. So that is to say, when you have an injured worker, they're initially injured and they go to the hospital with an emergency department. Where they're going, that is a general acute care hospital. And the only real option when they leave to stay at a general acute care hospital is an inpatient rehab facility. When you get into the other types of rehabs and skilled nursing facilities, those generally fall under skilled nursing, and you're not going to get the same care that you would get at an inpatient rehab facility. In fact, those oftentimes those facilities will have a few hundred minutes a week dedicated to inpatient rehab, but an IRF, we actually have to provide about 3 hours a patient day. So roughly 3 hours every day they're here, or 15 hours over seven days for a week is how much we have to give to maintain our status as an IRF. We have comprehensive inpatient services and then special designations. We have stroke specialty service and we have amputee specialty services through CARF. That's the Center for Accreditation of Rehab Facilities. So per the CARF website, through a CARF accreditation, San Joaquin Valley Rehab demonstrates the value and quality of our services by meeting internationally recognized organizational and program standards. And we actually just completed, that's something we have to do every few years. We just received that for the next few years also. And then also, you're going to find that IRFs are Joint Commission accredited as an acute care hospital. So it's not, this isn't going to be a vastly different thing than from your short-term acute care hospitals. We're held to that standard. We have to have, an IRF has to have a, for example, we have to have a laboratory. We have to have an X-ray department, radiology. We have to have a pharmacy. Those things that any other large hospital has to have, we also have those as well. And the Joint Commission, of course, they hold IRFs to the same standard. And then we have here, we have physical medicine and rehabilitation specialty. That's what's called a PM&R. And that's a physician that all they do is determine how well the patient's functioning and what they need to do to function better. And then we have 5-to-1 nursing ratio, which is going to be much better than, say, a skilled nursing facility ratio. We have physical therapists, we have occupational therapists, and we have speech therapists. And the important thing about having these three specialties is in order to meet the obligations of, generally the obligations of an IRF, a patient must need 2 out of those 3 if, say, they are a CMS patient. It's not really necessarily true in terms of work comp, but I will still say we do have physical, occupational, and speech therapy for those patients as well. And then we have respiratory therapists on site. So for an IRF like ours, we have diagnostic hallways, and that would be 15 licensed therapy hours over 7 days. And then we have here 4 hallways, and I think you would find this at most any IRF, that there is specialty training for each of those areas. Again, licensed nurses, 5-to-1 ratio, which is generally what you're going to find in most every hospital outside of critical care areas in California. Those areas you would find anywhere from 4-to-1 or 2-to-1, but quite generally your patients are going to be anywhere 5-to-1 ratio. We have certified rehabilitation nurses. They are ACLS certified, which means if there is any type of emergency that the patient would have, like a cardiac emergency, that they are equipped and can deal with those issues as they arise. We have wound care certified RNs, an infection preventionist, and then respiratory therapy as aforementioned. And then daily visits with the PM&R and pain management expertise. For capabilities, think more along the lines of if the patient stayed in the facility they were already in, what would those facilities be able to do if they are being discharged from that primary facility? Generally, we have those same capabilities, like hemodialysis. If your injured worker is on hemodialysis, has a history of hemodialysis, we can take those patients and we don't have to send them out. If they have a trach, we can decannulate trachs, and we can take care of those trachs while they're here. We have an area that's called a transitional living room. So we want to learn in our occupational, especially in our occupational area, what exactly can this injured worker do, and how do they get out of bed, and how do they sort of maneuver their activities of daily life. And we have a mocked up area that we can really find out those things. And that room we use often for our injured workers to stay there for an extended period of time. We can take care of critical illness myopathy. These are very sick patients. CHF exacerbation. This would be wound care, such as deglovings. We also expect the patient to be able to quite generally be able to perform 3 hours a day of inpatient therapy. Now, again, we can stretch that out over 7 days, and with this being work comp, we can kind of, or for the work comp patients, for the injured workers, we can kind of move those things around if the patient is maybe, say, lower or higher functioning than what we would expect for our typical patients. But they do need to be able to participate in therapy and actually want to and are able to. The average length of stay is from 12 to 14 days. For patients that aren't work comp, generally we stay around 13 days length of stay. That's not entirely true of work comp patients. Sometimes they're here much longer because we want to really be able to get those patients to the point of their maximum function. Okay, so who could benefit from an inpatient rehab facility? This would be strokes and bleeds, brain bleeds, and brain injuries, both traumatic and non-traumatic. We take many of both. Spinal cord injuries, again, both traumatic and non-traumatic. We can have those from surgeries, or we can have those from actual injuries out in while they're working. These are patients with Guillain-Barré, injured workers with any neuro or exacerbated neurodiagnosis. This would be neurosurgery patients with neurologic deficits, West Nile patients, Parkinson's. These are patients with anoxic brain injuries. So it would be amputations, and we're really going to get into that here in just a bit. Multi-system trauma, multiple fractures from the hip or pelvis. And these would be knee or hip replacements. We take care of a ton of both knees and hips here at San Joaquin, and all other IRFs do as well. Arthritis exacerbations, and then medical debilitations or med debils. These would be your CHF, COPD, coronary artery bypass graft patients, and patients that require really prolonged hospitalizations. And then your myopathies and burns. All of these could benefit from an inpatient rehab facility, but also know that even if it's not on here, and certainly keep this list, but even if it's not on here, if your injured worker could benefit from 3 hours of inpatient rehab daily, and our physician takes a look at them, or any of the IRF physicians in any IRF take a look at your patient and say, hey, this patient would definitely benefit. It doesn't necessarily have to be hard and fast on this list. That probably many of them will work. And I'm going to turn it over to Meegan. Thank you.
Hi, My name is Meegan Kliewer. I'm a physical therapist here at San Joaquin Valley Rehab. Get in the middle. I'm going to just be talking about some very specific examples of some of the injuries that we have seen in our patients that we have served that have been injured workers. When we look at a worker coming in, obviously being driven by their diagnosis, but all of the comorbidities that go along with everything that's going on with them. The first category that we'll be talking about is amputees. Now, we frequently see lower extremity amputees in acute rehab, but we have also obviously treated upper extremity amputees as well. When we talk about phase 1 versus phase 2 in the rehab of amputees, phase 1 generally means that the patient just had a recent amputee. So there are most likely still staples, edema. Our real focus here is wound healing. So we're looking at shaping, really projecting towards prosthetic fit eventually once they have fully healed. So our goals in inpatient rehab for the amputated worker, obviously really driving towards return to work. That is our ultimate goal. We, even from day one, even in the very, very acute phases, knowing that they were an injured worker, we really want to drive towards what did you do for a living? How do we get you back to that? So what is their job description? Do they have to do a lot of sitting versus standing, walking, climbing, bending, stooping, carrying objects? All of the things that go into the rehabilitation. Now, I'm a physical therapist, so when I go in to evaluate a brand new phase 1 amputee that maybe has just been amputated a few days ago, I really am looking at, of course, the wound, the edema management, the ACE wrapping so that it can be shaped, but also how are they going to get in and out of bed? How are they going to get into a wheelchair? Is there some ambulating that we can do right now, hopping on one leg? What assistive device do they need? The occupational therapist then will come in and see how are they going to do bathing, dressing, toileting, all of the activities of daily living. And obviously that's where we start with acute rehab because they are so acute. We are driving towards a safe discharge to home, but also from the very beginning projecting, like I said, back to return to work eventually. So what kinds of training can we offer them right now, even in the very acute phase, knowing that that is our end goal? Another phase of amputee, we call it phase 2. So we can also bring back the patients into our acute rehab program after they have already then healed from their phase 1, and now they are ready for a prosthesis. We often do coordinate with the local prosthetists so that they will get their fitting and be completely ready to put that leg on. And then if we can qualify for them for acute rehab, they can come in for a rehab stay then to get very aggressively up onto their prosthesis. So it's a lot of fun. There's a lot of very dynamic things that we can do as long as they're well healed. And we are then getting them up on their feet, doing all the activities of daily living, all of the, driving towards work activities with that prosthetic leg on. So getting them to a point of then being able to be very successful at home, up on their legs, so then they can keep pursuing rehab on an outpatient basis. One thing that I can remember specifically with one of my phase 2 amputees was that she was a farm worker and she had to get back to climbing stairs, climbing ladders eventually. And she had a very short residual limb. It was above her knee. So her prosthesis was built with a very complicated knee joint, but this was just the first prosthesis, so her knee joint was locked out. So we have to start at ground zero with the locked out knee, but then we were able to progress to unlock, and we eventually were able to get her down into kneeling on the floor, back up off the floor, and started climbing stairs with her prosthetic leg on. So that was exciting. Spinal cord injuries are the next injury that we frequently treat. That could be any level of the spinal cord, and every level has its own nuances of what we expect for function as far as what we expect for the way that we will treat them. If it's someone with a high level in the cervical spine, then their arms and legs are affected. So they have a lot more adaptive equipment that we need to look at for them. We did recently have a patient that was at a C5-6 level, and we knew that he was wanting to return back to work, and he worked in a big, was like a warehouse situation. And so in discussing with him, it would be very appropriate for him to be able to drive a power chair at work. So we were teaching him how to maneuver in a very large area, but also maneuvering objects with his power chair, and then also driving towards being able to get voice activated software, because his hands, he did not have fine motor control, but there was so much computer work that he did also for his job with payroll and everything that were in his duties. So we were able to set him up with resources for all of that as well down the road. So obviously his first very traumatic injury, he has bowel bladder issues, he has all of the ADLs in function that he has to be able to get back to, but really then projecting out eventually, where are we going to get him to be able to return to work? Traumatic brain injuries are also a big work comp injury that we frequently see. We can take them in acute rehab, usually above the Rancho 6 level, because when we look at that, the Rancho level is 1 to 10, and you're looking at cognitive function. So if you get 6 and above, then those are the patients that are the most appropriate to be ready to learn and to be ready for the carryover that it requires for intensive rehab. So the lowest 6 is a little bit dicey, but sometimes patients will vacillate moment to moment. Sometimes there's a 4, there's a 5, there's a 6 emerging. So we can really work hand in hand with the speech therapist in looking at that patient's cognitive functioning. A Rancho level 6 is confused but appropriate, so they are able to follow simple commands. So when we look at screening a patient to see how appropriate they are for acute rehab, we look at everything, cognitive functioning as well as physical functioning. The other injuries that we see a lot of are orthopedic fractures. We have had patients with fractures everywhere. Bilateral legs, bilateral arms, ribs, spine, all on the same patient. And sometimes we have had in the past bilateral non-weight bearing, not able to bear weight through either leg, and an arm that couldn't bear weight. So we had to be very creative in how to get this person functioning again as best that he could until he got his weight bearing increased. So we worked a lot on special techniques and special tools to protect him and keep him within that non-weight bearing status, but also get him up and moving every single day. And he was up in his wheelchair all day long, every day, doing all kinds of therapy within his pain tolerance, of course. There is a lot of pain management that goes into the orthopedic fracture patients. Let me see what else I was going to talk about. Also with the orthopedic fractures, obviously we have to look at how do we return them to work? How did they get injured in the first place? And what is their job description? So with the patient that I'm thinking of, he had to climb a lot of ladders. He was up on scaffolding. He was up really, really high off the ground. We are not going to get him back to that level until all of his bones are healed. But in thinking about what does it take for even baseline to be able to even get to a place of being able to climb a ladder is really maintaining all of the strength in the muscle function that he does have while the bones heal. Degloving and wound care is another big area of injury. Oftentimes these patients have a very long healing time. We see wound vacs, we see home with home health, and then waiting for their flap surgery. Then they might go back for surgery. If it's a full degloving, they may go and do many different surgeries to get that wound to be closed. And so they may go in and out of inpatient rehab as they progress through the healing process. And we are maintaining strength, we are maintaining range of motion, and of course, the highest possible functional level while they are healing through all of that. So I will pass it back to Jenni, and that's all I have for now. I don't know why it's not progressing to the next slide.
Thank you, Meegan. All right, I'm back. Yeah, I don't know why it isn't progressing either. Oh, there we go. Very good. False alarm. So how do you get an injured worker to an inpatient rehab facility? Well, there's a couple, IRFs have a bit of a superpower. We're the only level of care that can direct admit a patient from any location. We can, obviously, if the patient is it's a catastrophic injury, they were sent to a trauma center. We work with those hospitals quite a bit. They work up the patient, they do their surgeries or whatever was needed, and then they move the patient on to the next appropriate level of care. That's a process that we're very familiar with. There's also the locations of the patient maybe was sent home, and at the time that was an appropriate level. They were provided with certain services to be safe in the home, and family involvement was there, but possibly something changed, and the situation in the home setting is no longer the safest place for them to be. Also, if the patient sent to a skilled nursing facility, maybe that was the appropriate level of care when they were ready to discharge from we call them STACs, the standard acute care hospital. So when they were ready to leave there, the nursing home was an appropriate level. I'll go through a little bit about the pros and cons of that piece, but we're able to admit patients from any setting. So that skilled nursing level, if they are at home, we can admit them from there. That is different than a nursing home needs 3 midnights in the hospital to be able to admit a patient. Same with LTACs, long-term acute care hospitals, the more respiratory vent location. And so we do have that piece that's a little different. Inside, we'll work with, we have a team of clinical liaisons. They are made up of either therapists, respiratory, nursing, many different skill sets, but they're clinical, and they evaluate the patient to see if they are an appropriate patient. You're going to learn about the 17 hours a week that we're able to work with that, or 15 hours a week that we're able to work with them, and making sure that patient understands what they're getting into when they come here, and that we're able to take care of them and do what we're getting into when they come to us. So we go through the insurance process. We will work with doing the RFA, and just can support with any clinical pictures that are needed. Also, the inpatient rehab facility level of care is the only level of care that requires a rehab physician to evaluate and approve and accept the patient. That is different. Again, skilled nursing really, they can say yes or no to any patient. It does not require a physician to oversee that. Same with an LTAC. We will also work out the compensability piece, making sure that we work with the work comp folks that this has been a covered claim and that we're authorized to accept and treat that patient. This can take up to 2 hours, but that truly is probably on the long end of how quickly we can get an answer as far as being medically accepted. So why move a patient from the STAC to the IRF? In working with injured workers and mostly catastrophic injured workers throughout the years, there have been stories around the financial piece. When a patient does land in a trauma center and maybe they're on the ICU floor or neuro ICU, just we know the costs in that setting can be very high. We still are licensed as a general acute care hospital. There's a lot of benefits around what that looks like, but truly having that injured worker move from that trauma center or STAC location to an IRF, you're going to just save money on the claim already, with still having that high level of care with physician rounding daily, same nurse to patient ratio as a med surg level. The therapy is beyond what you will receive in an STAC. An STAC, that's not what they're made for. They're made to keep you alive and put Humpty Dumpty back together. But as far as the recovery piece, that's just not what they're staffed for. We certainly know that if y'all experience and work in that space. So that is the benefit of moving a patient. Also, because of that high level of care, the nurse to patient ratio, the doctor laying eyes on a patient every single day, you're going to avoid that patient having to return to the acute setting for having other complications that may arise if they went home or maybe went to a nursing home where the staffing is in a different model. And so we're hopefully avoiding any sort of infection with the wound, any wounds that were there or surgical sites, avoiding that high probability of an infection. So that's sort of kind of a comprehensive look of why the quality is what it is at an inpatient rehab hospital. There's hospital settings. We were just talking about this before this starts. This isn't, most post-acute facilities are used to dealing with more of a chronically ill geriatric person. They have been possibly in and out of the system with their taking care of their health care. Maybe they've had a decline. I joke, nobody's getting out alive, right? So we're all going to go through it. And but this is such a different issue. That this was just mom or dad went to work and now life has really changed. So our internal team understand that piece of it, and that's important. I had a injured worker share with me that they were very happy that they had this consistent nursing team. At the STACs, the shift changes quite a bit. Somebody's going to be on a different floor than maybe they were yesterday. And having that consistency, the injured worker was sharing that he was very happy that he didn't have to retell his story because people would walk in going, wow, what happened to you? And he had his consistent therapists that were here, his consistent nurses who basically build, during the time that he was with us, build quite a relationship with these folks. And so that really added just to the value for him in his recovery. So challenges, right? I just mentioned a few. We'll notice many times that when an injured worker does end up in the hospital, they're bringing together family members that maybe shouldn't be together, maybe once a year at Christmas or something. But other than that, so the family dynamics can be very heightened. It can be very scary for the families. This is now a potential financial hardship on them. They're having to drive to a trauma center that's $20 a day to park. Just little things that they're starting to really add into that stressor, let alone their loved one being completely potentially completely very different from when they went to work that morning. I'm working on a injured worker right now who there's an attorney involved, and the adjuster and the risk manager are asking me to coordinate with everything with the injured worker to get them in for care. Because they are not allowed to be able to speak with them at this point. And so we're able to be that that liaison, if you will, to make sure that they understand what to expect when they get to inpatient acute rehab and what they want out of it, right? So we know their expectations as well. We work with many non-clinical adjuster folks that a catastrophic claim may not be something that's their daily claim that sits on their desk. So working through, we understand that. I know that there is no fee schedule for us. So we work through whether it be contracting or single case agreements. The participation in all the MPNs is key. There are, I understand all the requirements that are required to bring in an injured worker. And along with, if it's an outpatient surgery, we'll have surgeons and schedulers where they give us the lead time to be able to prep and make sure that we medically can manage after the surgery, but also have all of our ducks in a row, if you will, to provide that care via the authorization and all of that process. So how we provide that solution is making sure that we understand comp and all of the pieces to it, and also making as much in-network status as we can, so that's easier for the claims folks that are trying to get that injured worker to the best level of care that they require at this time. So skilled nursing, there is obviously a need for that in the healthcare system. There are patients that is the safest and best level of care for them, and that is what they are great at doing and caring for. We sometimes get confused with that level of care, so that's why I'm dedicating this slide to it. For I'll just go through the physician piece. PM&R, Chase talked about that earlier. That is a physical medicine and rehab physician. That is your primary physician who is seeing your injured worker daily. The folks at the physicians at the skilled nursing facility are usually internal meds, family practice, typically not a specialist, and they are required to see them within 30 days of their admission there. So big difference in the oversight of the physician. And from, I can just imagine from an injured worker aspect of it, of having that catastrophic injury, that having a physician see me every day would be quite a load off of me mentally of for seeing where my recovery is going to go. Now the therapy, that's our wheelhouse. That's what we do. So 3 hours a day, up to 15 hours a week. The 3 hours a day, that is a big misconception. I want to make sure I cover thoroughly. 3 hours a day, people have misconceptions that you're on a treadmill for 3 hours a day, or you're up and moving in our large gym for 3 hours. It's truly broken up throughout the day. The injured worker will have on their schedule, they know exactly where they're going to be from 1 to 2, from 4 to 5. You know, they have their full schedule, so there's no surprise parties for them on what their day is going to look like. And there are times that, and this is a Medicare rule that we have to follow, that 3 hours can actually be spread out into 15 hours throughout the full week. So if there's an injured worker that comes in and maybe earlier in the week, they were able to do two hours. I know quite a few of Meegan's examples, maybe when they first got here, the 3 hours was not a go, but we're able to make up that time throughout the week with them. And in that skilled nursing facility setting, they're getting around 5 hours a week. And I'm probably being fairly generous of that. I think they all are, again, doing the best they can, but sometimes the staffing just doesn't allow for that. The piece also with the nurse to patient ratio, so we have to maintain a med surg level, the 5 to 1. That can fluctuate anywhere from 8 to 1 in a skilled nursing setting, 13 to 1 I've seen. It really varies. depending on probably their staffing model. And then both settings do have a interdisciplinary team that are going to round and see the patients. We have the same. We have the PT, OT, and speech therapists. We have the nurses and the docs. But also when the patient is possibly needing the next step, whether it be working with the nurse case manager on the claim, making sure that they have the updated clinicals so that you all can make decisions, and working with the care and treatment of this injured worker. And that's what my social workers and case manager folks that are on site do. And they go bedside and they make sure that the injured worker and the families, we know that's such a big piece of this. It's not just the injured worker, but we're really a lot of times caring for the families on top of the PTOT and speech. And so making sure that they understand all of the things that we can provide and educate on. And so we've been doing this for so long that we hopefully can be a resource for those folks that are going through it. Now, I do have a slide. I don't, this isn't like a Q&A, but I'm always curious if you have questions about a claim that you've been on and really struggled with or something. We can always chat. I'm sure Diane sends out my info, so would always love to hear. I'll go through how can the acute rehab help. So again, I hammer this, the 3 midnights. We have this luxury of being able to direct admit a patient from any setting because we do not require 3 midnights. I have a claim that we're working on right now that the injured worker has been home, and again, the setting wasn't what they thought it was going to be. It sounded right and appropriate at time of discharge, but now that they're home, the setting isn't appropriate. She's very scared of re-injuring herself, and the family members are a little over their skis on being able to support her. So we can, I know the hospitals, they require, every other level of care requires that 3 midnight. And so a lot of times that's us breaking down that misconception that we do not have to have them have that 3 midnight stay. We can admit a patient same day when we've got everything clinically, a good picture of who this injured worker is. We admit 7 days a week. So no waiting on for weekends or for Monday to come for us to be able to do this. And we're happy to help anytime. Also, we take a multitude of other payers as far as managed Medicare, and the Medi-Cals and managed Medi-Cal settings. I leave this. So Chase talked about our CARF certification. We have the special designation for stroke for our CARF certification. So we went above and beyond just a straight CARF certification, and also with our amputee program, we're CARF certified with that specialty as well. And the American Heart Association says that inpatient rehab is by far the best appropriate setting whenever possible to get an injured worker there. I know stroke isn't much that you all deal with, but just thought that was nice PR from the American Heart Association. I think that is it, Diane. If there are questions, happy to engage.
Yeah, I don't see any questions, but you guys were very, very thorough and really shared a lot of information. It's great to hear that you have those extra designations. Our injured workers deserve the best, and it sounds like you guys do all you can to make sure they have just that. All right, well, I would like to thank you and Chase and Megan, okay, Meegan. For joining us and being our speakers, the very last one for this summer school series. And to all of you that have attended, it's been our pleasure to provide to you these extra CEUs. We will be back again during the regular months. We will still have webinars. You could check them out at the MacroPro website. However, in December, we will have our 12 CEUs of Christmas, as we always do. So we look forward to great programming. Please make sure you tell us what type of programming you would like, so we can fulfill your educational needs. Until the next time, thank you very, very much for joining us here at MacroPro and Friends. Bye-bye now.
Bye-bye.